Hello, everybody. I want to welcome you to an educational presentation and question and answer with Dr. John Viviano. My name is Steve Karstens, and I'm Chief Dental Editor of Dental Sleep Practice Magazine, a MedMark publication. In our webinar today, we'll review various bite registration techniques to understand the most important factors when taking that bite registration for the construction of a mandibular advancement device. Before we get started, I'd invite anybody to use the Q&A feature in the control panel to ask questions. I'll be answering some of those questions at the end of the session as time permits. To receive this continuing education certificate for the webinar, you must complete the associated multiple choice quiz. A link to the quiz along with the recording of this presentation will be emailed to all attendees an hour after this is ended. Now let's meet Dr. John Viviano, who I gotta say has to be the best host for any visit to Toronto anybody could wish for. Dr. Viviano obtained his credentials from the University of Toronto in 1983. He's a diplomate of the American Board of Dental Sleep Medicine, has lectured internationally, conducted original research, and authored articles on the management of sleep disordered breathing. Dr. Viviano's clinic is limited to managing sleep disordered breathing, bruxism, and teaching others about that. His clinic was the first Canadian facility accredited by the American Academy of Dental Sleep Medicine. He's clinical director of the Sleep Disorders Dentistry Research and Learning Center. He also hosts Sleep Disorders Dentistry LinkedIn discussion group, conducts dental sleep medicine CE programs for various levels of expertise, including a 65-hour mini residency, and administers the SDD, Sleep Disorders Dentistry Academy.com online learning platform, which includes the Sleep Club online mentorship. Lots of ways to learn from Dr. Viviano, so we're very fortunate to have one of the masters of dental sleep medicine help us with that start position, help us with that thing that the laboratories say is the most messed up part of record keeping. So thank you so much for joining us. Thank you for being here, Dr. Viviano. I'm going to turn the webinar over to you now to learn more about taking that bite.
Well, thank you so much, Steve, for the kind words, and you're welcome back to Toronto anytime. It was a fun weekend. Thank you for the organizers inviting me to do this. It's always a pleasure, and this topic is particularly interesting. The title is a little bit provocative, mythology at its best, because you're going to find that everything under the sun is being done. And we're going to be talking about this topic from an evidence-based perspective. So understanding that there's those clinicians out there using things that work in their hands. I'm not meaning to offend anybody. I'm just talking about this topic from an evidence point of view. So just a few photos of my office and teaching facility where we have a lot of fun. And a little disclosure, I maintain a sleep disorders dentistry practice, conduct research, provide educational programs. The facility and all programs follow AEDSM guidelines. And I'm a consultant advisor for various companies, but I have no vested interest in any appliance, device, or technology. So I pride myself in trying to be as evidence-based as possible and without any bias.
There's something else that we'd like to bring to the table here in the discussion, at least thinking, a better collaboration between physicians and dentists.
Can I make one comment based on what Don just said? I think there's, if we're going to talk about the success of, oral appliance, moving into the future, I think there's one thing that we haven't discussed that's kind of the elephant in the room that probably needs to be put out there, which is there's a lot of distrust between the sleep physicians and the dentist, right? The dentists feel like the sleep physicians, don't believe in their product and are just trying to make a lot of money, and they're trying to do things that are outside their scope, right? And that's how many sleep physicians feel.
So there you have it, right from the horse's mouth. Dennis Wang is a top researcher, clinician, sleep specialist. Distrust. This is what we're dealing with. Well, why wouldn't there be when we approach them with, hi, I'm a diplomat of the American Board of Made Up Stuff. In order to earn the physician's trust, we need to be evidence-based. And so the topic today is oral appliance bite registrations. What does the evidence tell us? So we're going to review various popular bite registration techniques and the supporting literature, attempting to shine a light on what really matters when taking a bite registration for construction of a mandibular advancement device. Just to review quickly, the learning objectives: relate jaw position to its impact on the airway, discuss popular bite methods and the literature support or lack of, review important evidence-based considerations, what really matters regarding start position, end position, and maintenance. So a bite registration captures the relationship between the dental arches, which is used to manufacture a mandibular advancement device. We'll learn that there are many different approaches, including not taking a bite registration at all, which is very interesting. To start off, we're going to relate jaw position to its impact on the airway. Now, we've known this for a while. Man is the only animal with a floating hyoid bone. So there's implications when the jaw drops open, VOD increases, that hyoid bone drops back. Of course, the epiglottis is attached to the hyoid bone, and so therein lies the problem. This study was done in 2004, evaluating 14 non-apneic men. And what they did is, at 75% of protrusion, they increasingly increased the vertical. And what they found is that the airway got smaller. At the velopharynx, at the oropharynx, and at the hypopharynx. Okay, this is not a good thing. 2012 sleep endoscopy on 40 individuals, 32 of them, when they increased the vertical, there was an adverse effect. 1 got better, and 7, no effect at all. It was neutral. But we've known that it can lead to increased respiratory resistance, which, of course, is associated with increased collapsibility of the upper airway, which is likely the problem much of the time when it is a problem. Let's look at how conflicted the research is in this area. This was a study using the OSA herps and OSA monoblock, 75% advancement, 4 to 6 millimeter VOD versus 5 to 10. There was no statistically significant effect on efficacy, but the patients felt that the monoblock was more comfortable and they felt it was more effective and easier to use. Okay. This is a study everyone quotes, a PETSA study out of Sestuli's lab, 87% advancement. And then they did a sleep study with the VOD on the appliance, which was about 4 mils, then increased by putting an insert in there, 10 millimeters to 14, found that there was no increase in efficacy and that the minimal was more comfortable for the patients. This study is quoted all the time. Interestingly, the same year, another result, but this study is hardly ever quoted. They used Kowalski activator versus a silencer, 75% max protrusion, then 5 millimeters versus 12 millimeters VOD. And the higher VOD got a statistically better outcome. But Rose's study is not quoted often. 2001, our friend Don France published a little case study that was interesting and provocative at the time. He made an EMA. It broke, needed to be replaced, so he made a new one for the same patient. It didn't get the same result. When he compared the old and the new appliance, he saw that he had decreased the vertical. So he increased the vertical, and voila, the appliance was doing the job again. So he published a case study back then on the value of perhaps increasing the vertical. This was in 2001. So effective VOD as of 2006 is unclear. There's continued speculation with little evidence. Larger overbite is associated with better outcomes. So this study concluded that more VOD perhaps was responsible for the better outcomes. This is speculation. Systematic review and meta-analysis just recently published in 2023 No correlation between VOD and increase in outcomes. Interestingly, the studies that qualified for their meta-analysis evaluated VOD between 1 and 5 millimeters. That is hardly representative of what's happening with increases in VOD. So that's not helpful at all. 2024 VOD is still an open question. Literature is conflicted, but there seems to be support for minimizing VOD. Let's talk about optimum advancement now. Mandibular advancement results in increased upper airway volume, laterally widens the velopharynx, reduces tongue retrolapse during sleep or tongue falling back, moves the hyoid bone anteriorly, which is a good thing, stabilizes the epiglottis and soft palate, and reduces the posterior rotation of the jaw. Ferguson published 2006, AHI improves with increased advancement. Multiple studies have investigated the most effective start position, balancing adverse effects against time to reach endpoint. Obviously, if you start further forward, you may have more side effects, but you'll get there faster to that endpoint. So you have to find some type of balance. Inconsistent posterior reference, unfortunately, makes these comparisons difficult. Meta-regression analysis of 13 RCTs, no significant improvement with increased advancement, high inter-individual variability to advancement, and high inter-individual variability also reported by others. Recommended start position varies from 25% to 75%. And then you can say, of what? Because they use different reference points as that range. Is it habitual posture? Is it retrusive? Meta-analysis of 13 RCTs, advancement of greater than 50% did not influence success rate. Side effects increase with increased protrusion. Greater advancement is associated with lower adherence and greater side effects. Studies show that 50% advancement may both minimize side effects and improve AHI. For some patients, habitual occlusion itself can significantly reduce AHI. So you can see we're all over the map. Therapeutic position for mandibular advancement devices varies between patients. This was the Matrix Plus validation study, and you can see that it's remarkably similar to the in-lab Matrix validation study. Almost exactly the same results, where they have about 38% of the range being the starting point where the first person was helped, all the way up to close to 100%. And 70% seems to be the mid-mark. So 50% of the patients were helped with less than 70% advancement, and 50% of the patients needed more than 70% advancement. Then, of course, you have mild, moderate, and severe being distributed over this entire range. One would expect that the milder cases maybe wouldn't need much advancement, but you have some mild way up close to 100% here, the circles. The moderate is distributed over the whole range as well. And interestingly, some severes were helped with maybe about 55% of advancement, and others needed to be all the way up to 95 or 100% of their advancement. It's all over the map. For those not achieving the therapeutic success with what the Matrix determined, they needed an additional 2 to 4 millimeters to get to an optimum position for them. So why is this important? Finite element analysis studies show that the minimum and maximum forces occur 40% of max protrusion and 70% of max protrusion. Other finite element analysis show that the positive relationship between the amount of advancement and TMJ stress and this relationship is practically linear. So the more we advance the patient, right, the more liability we're taking on for that patient. So conflicting data with optimum advancement, no benefit beyond 50% of advancement. Optimum benefit was 70% of advancement, 50 and 75% advancement, equally effective with mild to moderate OSA, support for mild degree of advancement, and support for high degree of advancement. Remember what the matrix study shows us. The literature is conflicted, but there seems to be support for starting minimal and progressively advancing towards the most efficacious position to avoid side effects, or at least minimize side effects. So let's discuss popular bite registration methods and literature support. We'll start off with the pharyngometry-based bite. I've been involved with pharyngometry since 1999 when I purchased my first pharyngometer, and was really intrigued with the possibilities it had. Dove in deep, read everything I could get my hands on from the literature, published in Cranio, Sleep Review, and Sleep and Breathing, review paper on it, then got involved in doing some research. This was some work with Philips Respironics. And then just recently, actually in 2022, I published a Journal of Dental Sleep Medicine. So this is a topic that's near and dear to me. There is plenty of evidence in the literature that acoustic pharyngometry works at baseline and documents the airway. As a matter of fact, not only does it document the airway, we can differentiate apneics from non-apneics, and even snores from apneics, and males versus females, and obese versus non-obese. Age is actually differentiated. We have normative standards published. All of this is great at baseline. Apneics have a smaller, floppier airway that occludes at end expiration. Acoustic reflection differentiates disease, gender, obesity, and age. Over 40 years of excellent literature with acoustic reflection, yet there's not one randomized controlled trial demonstrating the clinical utility for oral appliances and management of OSA. So you have to wonder what's going on here. This is a study published in 2020. I can't see the end because talking John Viviano was over it. But 16 males and 10 females, so that must be saying 26. And of 26, no BMI mentioned, okay? No control group. Now, we know that the acoustic reflection information you're getting varies based on BMI and gender, okay? Yet, the use of the pharyngometer was essential in the results, but there was no acoustic data disclosed, and there was no thresholds disclosed. The VOD they used in this study was from 4 to 10 millimeters with very little advancement. One of the things they claimed was that they ended up with a bite that was a lot less advanced than you get using the usual customary protocols with the George gauge. But the secret ingredient here may be related to the higher vertical, and we'll talk more about that. This is another study with an N of 120 and 75 males, 45 females, no differentiation in the data, even though they present differently with acoustic reflection. BMI ranged from 21 to 38.8. Once again, that range is huge, and they represent differently. What you're going to see is different in an obese individual versus a non-obese when you measure the airway with acoustic reflection. No control group. Acoustic pharyngometry protocol applied seemed to contribute to the excellent effect of the oral appliance. Yet, they say that the acoustic pharyngometry measures were not significantly associated with failure. So it could not distinguish if the appliance was not going to work. Yet it's contributing to the excellent result of the oral appliance. I find those two statements contradictory. VOD, 4 to 12 millimeters, mean was 5.6. Now, this one's advanced a bit more to about 71%. Here we have mandibular advancement of obstructive sleep apnea relating outcomes to anatomy, N of 75. Success not predicted by identification of region of maximal upper airway collapse measured with pharyngometry. Study with 576 patients, utility of acoustic pharyngometry for the diagnosis of obstructive sleep apnea. The mean cross-section of the upper airway at FRC, functional residual capacity, when sitting or supine, provided no further significant advantage over clinical variables for discernment of OSA. This is when I had my personal aha moment, because I tried for a very long time to come up with clinical protocols to validate the use of pharyngometry. I had my aha moment when I was working on this project with Respironics on trying to develop a better nebulizer. And this is what occurred to me for the first time. It's like that light bulb went off. This is how acoustic reflection works. Sound waves travel down into the airway. They bounce back, are picked up by the little microphones in the pharyngometer, and then you see the acoustic wave with the pharyngogram on the computer screen. Now, there's a requirement. The nasopharyngeal seal needs to be closed, because if it opens up, if that soft palate drops off the posterior wall of the airway, the sound waves travel up into the sinuses and back down, and distal to that point, these two volumes are added together. So when you look at the screen, it looks like the pharyngogram got bigger. You increase the size of the airway. But my hypothesis here was that you're actually looking at tainted data. You're looking at the addition of these two volumes. I don't know why it took me so long to come up with this, because they know this in rhinometry, and it's published in rhinometry using acoustic reflection, same technology to measure the nasal passages. If there's a perforation from the right to the left, it's considered noise distal to that perforation, because the sound waves travel up one side, over to the other side, cross over, and it all comes back jumbled, and you have noise. You don't have accurate representation of the nasal passages anymore. That is published on for rhinometry. So what we did is, because I was working with Philips Respironics, they have this stuff. We got a cast of a human airway. And then we went to Rhoda and picked up some T-tubes and glue and put everything together. And as you can see, there's I'm drilling a hole, creating a leak at the nasopharyngeal junction. And we created increasingly larger leaks into two T-tubes representing two different size sinuses. And this is what we found. Area under the curve 1 is the oral cavity. Area under the curve 2 is the oropharynx. Area under the curve 3 is the hypopharynx. So first thing, the volume increased. In other words, that resin cast got bigger right before our eyes, distal to the leak. The next thing is in the oral pharynx area, the volume of the leak increase was related to the size of the leak. In other words, the bigger that leak became, the bigger the oral pharynx became. Then in the hypopharynx, further along in that cast of the airway, the volume increase was related to the volume being leaked into, like the smaller versus the larger T-tube, and to the size of the leak. So in essence, we all know what happens when you open the vertical or when you move the jaw forward. We know one of the things we want to happen is to open up that airway, even behind the soft palate. So it's implausible, it's impossible for that soft palate not to pull away from the upper airway. We need to have that intact in order to prevent the sound waves from traveling up into the sinuses. Now, phonetic-based bite, for the longest time, I just could not understand how this could possibly work. I bumped into Daniel Clower at the ADSM, and he started talking about the phonetic bite, and I literally just looked at him, and I didn't know him. I said, does that thing even work? And he, of course, he went on about how he uses it every day. So I challenged him said, I'm going to send you a spreadsheet. I'd like you to populated with 20 consecutive patients. I'm going to do the same thing, use George Gage technique, and we're going to see what happens. It ended up being published. It was never intended to be a study that we were going to publish. It was just a little, two guys bumping into each other at the conference and a challenge. But the results were so intriguing that I thought this was worth publishing, because there'd be nothing in the literature on this, really. So the first chart you see was his data and my data, and there was no difference in outcomes, okay? So then we were so intrigued by this, we got data from 4 different offices, 5 patients each on the phonetic bite side, and the same thing on the George Gage side. And once again, there was no difference between the outcomes taking a bite with a phonetic bite versus the George Gage. Now, Of course, there still is nothing in the literature. This was published a couple of years ago, 2020. Insufficient information exists. They wanted to do a systematic review, but they were really sort of prepping the stage for a study that is ongoing right now in Edmonton, where they are actually evaluating the clinical utility of the phonetic bite and looking at side effects, adherence, outcomes, and so forth. So once that study gets published, for the first time, we'll have data in the literature that's official and properly done on the phonetic bite. Now, what about the vertical? It's, what do you do? Where do you capture it? Well, it seems that you have to accommodate different appliances, so you have to capture it to make sure you have the right vertical for the different appliances, right? Here we have a little case study published by David Rawson. Quoting him, component that provides significant reduction in AHI is added vertical. I increased vertical in the bicuspid region to 10 millimeters between the arches. You can see the pictures of this DSAD as part of his case study that he published, with very good results with moderate and severe patients. So apparently you established a vertical by the appliance design or whatever you wish. So I'm going to tie these two things together, acoustic reflection and phonetic bite. They don't have any supporting literature other than case studies, yet they seem to be associated with good outcomes, and there's people using them all the time. So I wonder what might be happening here. The common element could actually be increased vertical. And I'll be talking a little bit more about that in future slides, tying it all together. So just hold on to that thought. Awake, snore, sound-based bite. Well, there is just nothing in the literature to support this. Neuromuscular, applied kinesiology, applied muscle testing. There's clinicians throughout North America, and I'm sure Europe, using this technique, and they swear by it, and it works great in their hands. But unfortunately, there's no supporting evidence in the literature, so there's little to talk about. This is a new approach, getting rid of that slant, the Moses X slant-based bite. It's intriguing, it's interesting, but it would be nice if we had some evidence to look at to demonstrate the clinical utility and that actually provides a different outcome. Then we have a theragnostic approach. Unfortunately, we lost the matrix, which was literature validated, and I used it for severe cases on a regular basis. A great product, and sorry to see that it's not here anymore. We have the apnea guard. This is a very inexpensive and easy to use tool. It was based on the work that Dan Lewandowski, together with Todd Morgan, what they found that males seem to benefit from a higher vertical, females from a lower vertical. And other studies, when they were validating the apnea guard, they found that if you take it to 70% max protrusion, you're within 1 millimeter for 80% of patients. So they were excited about that. Didn't get much traction. But on another study, they showed that if your patient is managed with an apnea guard and it gets it to less than 10, then there's a fourfold, increase in rods that your custom appliance will get you to less than 10 as well. So we have three verticals on the apnea guard, and you can either use the appliance itself and submit it as the bite, or you can scan the bite and have the patient continue to wear the apnea guard while the appliance is being fabricated, and you can then make the appliance of choice there. Now, we have construction parameters, and we'll be discussing those parameters in slides to come, and there's various tools available. But these are tools. These are not techniques. These are just a tool to capture a bite registration. George gauge, Stom gauge, and Pro gauge are three popular tools used for that. And then there's no bite. Makes it easier for those new to dental sleep medicine, perhaps to put the therapy into ENT's hands or other physicians. Well, this is offered by ResMed in Europe for the Narval appliance, and I hold serious concerns. I am concerned about dropout due to discomfort. I'm concerned about possibly the clinicians that this is such an easy entry for them that they don't bother to take the time to learn how to balance the appliance properly, to how to manage the patient through this. So I think dumbing it down like this might be a concern. Now, notice the question mark at the end. I have no data. This may be just a personal bias on my part, but I think that when I look at the effort I have to put into to make sure that the appliance is balanced left to right and that I'm respecting the trajectory of the jaws, we're moving the patient forward, I can't imagine dumbing it down and putting it into someone's hands that doesn't understand all of that. And you don't even have to take a bite in the first place, is going to result in the optimum outcomes. So they look at edge to edge versus full protruded, and you give that information to the lab. You document how much the appliance or the jaw deviates with advancement, and they use a minimum amount of vertical opening, and they make the appliance. Now, the flex tap also requires no bite, but the design of this appliance, you can see, because as you move the jaw forward, it actually opens up the vertical, is really not based on contact. And they provide little silicone pads if you want to have some type of contact in the back. So this is, a different concept altogether. Once again, Keith Thornton is taking things in a different direction. And of course, it's important to note that 14 millimeter range of adjustment. So he can manage patients very well with that. There's not a concern about running out of space. So next, we're going to talk about evidence-based considerations. What really matters regarding start position, end position, and maintenance. So some important questions. We've established that we got all these different things being done throughout North America and in Europe, and everybody's getting great results and it works in their hands. What you need to ask yourself, is your start point associated with good patient tolerance, minimal side effects, minimal dropout, optimum appliance design, access to optimum endpoint as efficiently as possible? And is your endpoint associated with long-term adherence, minimal long-term side effects, minimal long-term dropout, optimum outcomes, optimum appliance durability, and also allowing for future adjustments? This is what the evidence says about what really matters. So start position, the goal to achieve reduction of signs and symptoms of sleep-related breathing disorders, usually related to patients' chief complaints. We need good baseline assessment to refer to. So you got to get crystal clear assessment of how the patient presents. Seek position that optimizes adherence and limits short and long-term side effects. Select appropriate VOD for specific appliance being used, and also the patient phenotype, Dan Lewandowski's work, if you subscribe to that. Ensure VOD does not interfere with lip patency. We may have to resort to a mouth tape or a mouth shield. Actually, Steve Carstensen taught me on a webinar about this mouth shield that's provided by a local sleep physician out that way. And I thought that was interesting. I've mentioned that to a number of patients so far. Start position. Ensure the range of motion of the appliance and the range of the motion in the patient are aligned for optimum appliance design. In other words, you don't want to be at the end of that advancement mechanism, right? You want to end up somewhere in between to ensure that the appliance is as strong as possible. Otherwise, it could be stressing the mechanism such that it ends up breaking sooner than you'd want it to. Document and respect midline deviation with the jaw advancement. And there is no consensus regarding initial acclimatization time, advancement increment, or advancement time, right? But the ADSM recommends 1 to 4 week acclimatization before the appliance is advanced. I personally tend to set the patient up to advance at their pace. Some patients might need to have, easily a couple weeks of wearing appliance before they advance. But if somebody can advance quicker than that and still be comfortable, then I don't want to limit everybody to that extreme. I basically, when I do at-home calibration, I explain to them in each position, you have to wear it until you're totally comfortable. Then you're ready to consider moving to the next position. Now, for some patients, that could be 3 days, and for other patients, it could be 10 days. And I explain that to them so they don't feel that they're going too slow or too fast. It's very patient specific. Home or office advancement depends on the patient, right? Within 30 days post an insertion and on regular intervals, the patient is followed up for a reassessment of signs and symptoms with the same baseline questions, right? Advance as much as necessary, but as little as possible to minimize side effects, 0.5 to 1 millimeters per advancement. Sometimes I'll advance 1.5 millimeters, but usually it's either, I'm going to say most common is 1 millimeter at a time. Ensure to remain within adaptive capacity and advance to maximum outcomes. Now, what do I mean by adaptive capacity? Whatever you're comfortable in that's the adaptive capacity of your musculature, your joints, your ligaments. But we know that if we take somebody beyond, we're too far advanced for them, they're uncomfortable. So you want to stay within the adaptive capacity. We also know that with passage of time, the adaptive capacity increases because it's elastic, and you will then be able to tolerate comfortably that further advancement. And this is what we see in our patients. The analogy I like to use, if you go for a gym membership and your trainer sets you up with exercises that are basically within your adaptive capacity, but with passage of time, he's able to up the game and give you more challenging exercises because that adaptive capacity is elastic. It's the same concept. Factors influencing bite changes include treatment duration, right? How long they've been on the appliance, the use and frequency, like if they're wearing it every night, all night long, and the degree of advancement, right? Some patients respond adequately to nominal mandibular advancement. In this particular study, 30% best reduction, no advancement. 38% greater than 50% reduction with no advancement. 81% of mod to severe OSA, best reduction was less than 3 millimeters advancement. Mean advancement, 1.7 millimeter advance. Greater than 50% reduction is 72%. So we see all sorts of good things happening without much advancement going on. So if somebody's helped, remember that chart from the matrix validation studies, both of them. If somebody's helped with 40% advancement, why in the world would we want to burden them with 70% advancement just because we want to get to an endpoint faster? Okay, so we've more efficiently gotten them to a position of efficacy, but we have now increased the stresses on their muscles, joints, and ligaments, their teeth, for the rest of the duration of time they're wearing their appliance. I think we have an obligation to minimize that liability. Small mandibular advancement may be more efficacious than a larger one. Maximum comfortable protrusion may result in unwanted side effects. So 50% protrusion is a recommended starting position according to Arab. 25% protrusion resulted in significant reduction, 25%, right? 50 and 75%, even lower side effects, greater starting at 50%. So 50% seems to be where the side effects start to ramp up. Initial position varies with the VOD of the appliance, the phenotype of the patient, based on Lewandowski's work, if you subscribe to that, the curve of speed. You got a big curve of speed, you're going to have more vertical to be able to clear that as the jaw moves forward. The range of motion of the appliance and the range of motion of the patient, and quite frankly, the patient's comfort level, their adaptive capacity. So let's take a look first, establishing the appropriate VOD, right? Consider the VOD required for the appliance, the phenotype, if you're going to be looking at that information, the curve of speed, and you want to make sure you're able to maintain lip patency so that you don't compromise nasal breathing. Second, establish the initial advancement. Consider comfort, right? You want to stay within the habitual and 50% of full range of motion, within that range there. That's the range of motion of the patient. Now notice where I've positioned the range of motion of the appliance. What happens is, with time, the range of motion of the patient increases. Caution here is starting to aggressively, you run out of appliance advancement. Or I'm sorry, starting to conservatively, you run out of appliance advancement. Right? If you don't start off with a bunch of advancement, there's more range of motion, but you're maxed out on your appliance. But starting to aggressively, you burden the patient with unnecessary advancement. There's maybe adherence concerns and unnecessary risk of bite changes. And I can't state this enough, you always need to remain within the patient's adaptive capacity. Subjective improvement is insufficient. We know this. Adding objective data improves outcomes. Residual symptoms may improve further with continual gradual advancement, and residual symptoms may improve further with simply passage of time. Maybe edema will improve, the damaged muscle heals, muscle fatigue will recover, tongue hypertrophy is reversed, and sleep deprivation is improved. This is all published and proven to be the case with CPAP. The same thing applies with oral appliance therapy. Subtherapeutic result, maybe further advancement will help. Maybe use of adjunctive or alternative therapies. And the patient may elect to continue with the MAD despite the subtherapeutic results. At endpoint, the patient is referred to the medical provider to verify the treatment efficacy. So on maintenance, it's important to evaluate the appliance 6 months after reaching the endpoint and then yearly thereafter. Evaluate using the original baseline questionnaire always. Evaluate for signs of wear, fractures, bacteria, fungal growth, and replace according to the patient's needs. Always send an update report to the referring physician. And the medical provider should also be notified if the patient terminates oral appliance therapy as well. The patient's ability to tolerate further advancement increases with time. If required, further advancement could be considered at a future follow-up appointment. Regular annual follow-ups are critical to ensure continued good outcomes because patients gain weight, lose weight, become less fit, more fit, all sorts of changes happen. Now, this is an overview of what the literature tells us. We know that the German Society of Dental Sleep Medicine is very specific of saying you should start at 50% of advancement. Now, to standardize this chart, I'm using 10 millimeters so that we are comparing apples to apples, meaning full protrusion is 0, full protrusion is 10. And in this particular case, habitual protrusion, our habitual bite is set at 3 millimeters. So the German Society of Dental Sleep Medicine says start at 5. The AADSM says, look, we see good results from about 25% all the way up to 75%, but some people respond at 0. Some people respond best at 50, and over 50, the side effects increase. So how about this? Anywhere between 25 to 50% is a good place. Just pick a spot in there, okay? Now, this was recently published in a poster by Bream in Europe, and what he started is everybody at max protrusion minus 2 millimeters. And what he got is an outcome of 79% to get less than 10. Okay, look at where he's positioned as a starting position. And he's getting good adherence, good results, at least in the short term, right? Interestingly, a study done by Hokima in 2007, what they did is they started patients at 50%. And then when they did the PSG, if the patient was not resolved, not less than 10, they would be advanced and then sent home just for some acclimatization and then come back and do a PSG again. And this repeated until the patient could not tolerate further advancement or they were under 10. 100% of the 9 patients got to less than 10. Almeida published a similar study, 2009. What they did is start everybody at 60%. And then for patients that still had apnea, they woke them up, advanced them a bit, let them fall asleep again. This is within the same night's sleep study. And they kept on waking them up and advancing until the patient could not tolerate any further advancement or the apnea was resolved. 95% got to less than 10. So at 65% were helped with just 60% advancement, and with an additional average of 2.7 mils, 95% were helped by the end of that one night sleep study. Now, we know that Remmer's work on the original in-lab matrix showed the range from around 38% to 100%. 50% were advanced less than 70%. Once again, from about 38% to 100% advancement for the matrix plus validation study. In both cases, 50% were less than 70% advanced. We can see how all of this is lining up. And the other 50% were more than 70% advanced, right? We know that minimum forces from protrusion started at around 40%, maximum forces from protrusion around 70%. Phonetic bite, where many of the pharyngometry case studies and take a little advancement, more vertical, they're all around a little bit advanced from edge to edge, but with a lot more vertical in many cases. They're in this range. When we look at the study that's being published, the early studies were evaluating vertical. They were all pretty well at 70–80% of protrusion and then cranking the jaw open. They're all in this range. So they weren't really evaluating the same areas. As a matter of fact, this green zone that I have here, which is just a little bit beyond edge to edge to 4 to 5, this is uninvestigated territory. Research needs to be done on this, and the study that's happening right now in Edmonton is going to shed some light on this region here because we have nothing else published in this area. So the Panthera folks sit around this range here, around 6%. If you're giving them a fully protrusive bite, they'll bring you back to about this range here, about 60% protrusion, or you can pick the bite you want to start at. So you can pick anywhere between that 3 or 4 or 5 or 6, if you want to be more conservative. So you have the option of starting further back or starting at 60%, but you can see, that's a very reasonable starting point, 60%. That's not really a stretch. I think it's much more reasonable than starting people at 70, 80 or more percent to begin. So priorities. It depends on your perspective. The patient, chief concern, cost, tolerance, efficacy. I hope the insurance will pay for it. I hope I can sleep with it. I hope it works, wants to be comfortable and effective. The manufacturer, chief concern is efficacy and remakes. I hope there's enough VOD. I hope there's enough AP adjustment. I hope the registration is accurate. I hope Appliance is not fully advanced at any time because they know it's more susceptible to fracture, which they would have to fix under warranty. So that should be a concern to them, of course. And then the dentist. Well, chief concern is adherence, efficacy, and safety. I hope the patient can tolerate it. I hope it resolves the problem. I hope it doesn't cause side effects. They want it to be worn, effective, with minimal side effects. To be successful, the dentist must be aware of everyone's priorities and should ensure they are being satisfied as best possible. You need to be using the appropriate VOD, appropriate advancement. Final position needs to be appropriate for durability of the appliance. The accurate bite, respect to documenting deviation and vertical and so forth. Remain within the patient's unique adaptive capacity at all times. Advance as much as necessary but as little as possible, and monitor therapeutic outcomes both subjectively and objectively. Now, just to summarize the two Panthera bite options, you can take a maximum protrusion, and the lab will bring things back to a 60% start position. The appliances will always allow a 1 millimeter protrusion for wherever the start position is going to be. Or you can take your starting point bite, which is what I like to do. I decide where I want them to start, and they move forward from here. And once again, whichever bite is used, the Panthera DSADs and both of the X-rays are built to allow 1 millimeter retrusion. And at this point, I'm ready for some questions, Steve.
John, that was so comprehensive. I really appreciate bringing all that evidence in, because we guess so much in this field, and to have the confidence to say, okay, there's actual backing behind what I'm thinking is going to give our dentists quite a bit more confidence. And so that's really great. One thing I'd like for you to go over, I know you went over this, but please reinforce this, because there's still so much confusion about where to measure from. I liked the little graph you had towards the end, but could you restate that so it's super clear for everybody, please?
So yeah, unfortunately, the literature is inconsistent, and what both the German Society of Dental Sleep Medicine, American Academy of Dental Sleep Medicine, what both recommend is you go from full retrusive to full protrusive. That's the patient's range of motion. Right. And so when they're talking 25% or 50% or what, that's what they're talking about. I typically like to think in terms of where their habitual bite is, because that's already a comfortable starting position for them, because it's not a stretch for them to be in that position. So I will use that and go forward from there. But when you're documenting range of motion, to be consistent so that everybody can compare and is talking the same language, it's supposed to be full retrusive to full protrusive.
So that's easy to measure on, say, a George gauge or a pro
Sure.
gauge with a slider device. But when you're talking about a acoustic bite or a snore bite, there's not really a full protrusive to a full protrusive situation to do there, right? So if somebody wanted to use, I think your evidence showed that you could use a phonetic bite or a pharyngometer bite or a snore bite. They were all kind of the same. And so if somebody loved a particular technique, is there any downside for them just loving that technique and using the one that they love?
Well, this is what I said from the get-go. I certainly don't want to be offending anybody that's using something that they're getting great results with.
Okay.
Because maybe if some official studies were done on the technique they're using, we would see good outcomes, and we would better understand that they are useful. Without a randomized controlled trial demonstrating a clinical utility of a bite registration, it's hard to have an intelligent conversation about it. It's just like swapping recipes. You know what I mean? I make better muffins than you because I put a little bit more butter in or whatever. It's not, that's not science. So, remember I started with the distrust of physicians. And
Right.
so to me, it's very important to keep things as evidence-based as possible, because we are practicing in a medical arena. We're not doing dentistry. We're accustomed to doing things the way we do them in dentistry, which is like little recipes and following, what this manufacturer is telling you to do with the materials. And so this is different. This is medicine. And to earn the physician's trust, we should be following evidence-based protocols. And that's, maybe I'm too heavy on that, but I think that's very important, because that webinar that I participated in, I think that was 21. It was not a long time ago. It's not like they used to think that way. No, that is currently the way the physicians think of us. They don't trust us. We need to earn their trust by practicing in an evidence-based manner. I really feel strongly about that.
So if the evidence points now, what you said was, 50% for the Germans, you said, and then, many other research papers are showing that minimal advancement. You made that point very clear. the patient acceptance, I think, is something that's going to be a major portion of it. So could you expand on that a little bit more?
Well, if you see, okay, the Germans said 50%. They're very precise, which is, the culture. The US, between 25 and 50% is a good place to be, and, a little bit more loosey-goosey. And, quite frankly, there are some people that are helped with habitual posture, as you know, Steve. So, you don't advance the appliance at all. That's a small number of people. That's a small percentage of people. Typically you're getting closer to 50% before you're getting some type of effectiveness. Now you're getting, a substantial number of people. We know we're helping half of them, just less than 70%. This is why the Hokima study and the Almeida study was very intriguing, because one started at 50%, one started at 60%. You got a pretty good result. But to get the efficacy up further, they needed to do more advancement. And some of them ended up at close to 100% to get that. So what do we have then? We have the people that are helped with just 40 or 50% advancement. That would have been the Hokima study, and 60% for the Almeida study. That's all they got, because that's all they needed, right? But the ones that needed more advancement got more advancement. So
Right.
the people that are taking on the liability of more advancement in the way of side effects are at least getting the reward of having their apnea managed better, right?
Yeah.
The people that are adequately managed at 50 or 60% are not taking on liability with no benefit. Right. Yeah. And I think if we're going to be providing this therapy, we have an obligation to provide it in a manner that will provide put forth the least harm to the patient. And if you don't think that's harm, you think that's benign, or maybe it's not a big deal, I guess that's a personal decision someone has to make.
Well, one of the realities we face is in many of the times we see our patients, they've already, quote, failed, unquote, a CPAP device. And so I find it's really important to make sure that they don't fail an oral appliance for things I can control. And so that minimal advancement is something that allows them to get into therapy and judge later about efficacy without being a barrier of unacceptability.
Absolutely. Agreed.
Yeah. So one of the things is to point out too, is that you talk a lot about 30%, 40, 50, 70, 80%, but on your scale there of 0 to 10, the difference between 50 and 70% is 2 millimeters. So it's not a long distance anyway, right?
Right.
So we have to keep that in mind when we're thinking with our patient's range of motion. And by the way, I wanted to point out, I really loved your illustration of the adaptive capacity and how it changes over time. That was very helpful to keep in mind. Yeah. So as they change, then our devices have to be able to keep up with the patients. So what happens when a patient says, this isn't working? How do you know that they can go further forward? And what would you do differently at that point in a practice?
How do I know they can go further forward? I don't quite understand what you mean by that.
So somebody comes in and they say, well, I've maxed out my device, but yet my symptoms are still there.
Yeah. So they've maxed out the advancement capability of the device.
Right.
Right. Yeah. And so this gets into tricky territory, because this is obviously the clinician's responsibility. It's not the lab's, the manufacturer's responsibility, or the lab's. The clinician has a responsibility to pick a starting position and match it, and know what the range of motion that patient has, realizing that range of motion is likely to increase with passage of time, and then position the starting position appropriately so that they can get to their and then some, right? Now,
Right.
That's a decision. It sounds complicated. It's really not that complicated. You just have to understand the appliance, how far it can go, and take that into consideration. Now, this is where life is always a compromise. So you may be starting that patient a little bit further forward than you would really like to, because you want to use this particular appliance and it only has this type of range. And you need to position it such that you can get to that range and still have, more available to accommodate the further protrusion in the future. That's compromise. So life is all about compromise. So you have to decide which is more important. If you get to the end of the range I can't say that it's not the manufacturer's responsibility to make a new appliance for you. I mean, sometimes it depends which type of appliance it is. It can be modified to do that. And other times it's a remake. So that is, up to that. The safest way to do that, which is, I guess, what they do with the no bite, is they position it so that their starting position, is unlikely to result in, you running out of appliance, right? By starting aggressively enough. But now there's more side effects for the patient. Now, having said all of that, these side effects, it's not like the side effects are huge. As long as if it doesn't result in dropout, that's huge. That is not acceptable. As long as the patient can tolerate it, you have to decide, balance out everything, including, maybe we're going to have a little bit more bite change if we do this, but you're less likely to have other issues, right? Like appliance breakage or not running out of appliance. And this is where the clinician gets to make the decision as to what they want to prioritize.
I like to get patients into the device because and rely on that additional adaptive capacity later on should they need to go further forward. So I get them into a device and have them be comfortable to avoid the early dropout. Because the science says that early dropout is more common, and if we can get past that early stage, they're more likely to continue using whatever therapy they have, CPAPs, oral appliances, whatever it is.
Right.
Yeah. Exactly. So do all of the methods that you presented there, they don't all give us the full range of motion, do they?
All of them, I'm sorry.
Like a pharyngometer or a snore bite or a phonetic bite, do they give you can you write down the patient's full range of motion with those using those testing devices, or do you have to measure it some other way?
You have to use a different tool to measure a range of motion. Pharyngometer is just measuring the size of the airway using sound waves.
Okay.
So maybe I'm not understanding your question, but like you have to use something like a George gauge or a Pro gauge or a soft gauge to measure range of motion this way. Then the airway metrics allows you to measure vertical with different tabs there. But a ruler can do that.
Yeah. So and another thing I want to ask about is when you talk about vertical dimension, where are you measuring from? What vertical dimension?
Incisal edge
Incisal edge to incisal edge. So my bite is a real deep bite. I mean, I have 100% overlap in my lower incisors.
Right.
Somebody else comes in and have an open bite.
Right.
So how do you measure the differences there on vertical?
Yeah, but that's the thing. This is what that one study found, that people with a deep bite actually got a better, outcome, and they hypothesized that because they have a deep bite, they're ending up with more VOD than somebody with a shallow bite, and which is true because you got to, pass the teeth, and now you have whatever vertical you need to manufacture the appliance, right? So now, that's just speculation, that they were just wondering, they were pondering that question, so clearly you have to measure if somebody's got an open bite in the front, the way I would measure the VOD there would be whatever that open bite net needs to be subtracted from the VOD that in other words, the actual increase and vertical is what you want to measure. So, they open up to wherever, and then you subtract whatever their bite is open by. If they got 1 millimeter open bite, well, you can subtract 1 from whatever, and that's going to be the VOD.
Right. And you always have to keep in mind, like you said, what the device requires.
Well, yeah, that's in order to accommodate, to make sure you're accommodating the device. You need to accommodate the curve of SPI at the back as they're moving the jaw forward, and you need to have enough material for them to make the lower and the upper component of the appliance, which that number varies from appliance to appliance. So that you need to get from the appliance manufacturer.
So what do you suggest? Let's think about this for a minute. A dentist takes a bite registration, and they've chosen the proper protrusion, but they have insufficient vertical. What do you think is the best case scenario for that one when it reaches the manufacturer lab?
I find that when the manufacturers open up the bite on the virtual articulator, or even on a, actual articulator, I mean, it messes with things, and I have to adjust, in the mouth, when it gets back, on delivery. So I don't know what the answer is going to be as far as efficiency. They've got it. Let them make the change they need to make, and then do the adjustment in the mouth. Probably that's the most efficient, because what's the alternative? Getting the patient back in, and now that inconveniences them. Of course, it inconveniences the office and the lab. Everybody is doing extra work, so I don't know if I'm answering your question, but I think that the lab needs to make the adjustment, inform that they've made that adjustment, and then after, you take that into consideration and watch for it and adjust accordingly when you deliver it.
There you go. That's exactly what I was hoping you would say, because what I want the learners that are watching this to take away is that as you look over the evidence that Dr. Viviano's produced and you consider what method you're going to use, just get to do it correctly. Send your manufacturer the right information. Take everything into consideration. Not that hard, but just make sure you're disciplined to do it correctly, because you don't want to face that situation that John just talked about, where the laboratory has to guess and potentially send you back a device that needs adjustment, or you have to spend money, time, and trouble to get the patient back in, who has to spend money, time, and trouble just to make up for a bite that you didn't take correctly, right? So this kind of presentation, John, was excellent for our dentists out there taking bites, or in the real world, to study through this and watch it and look at the references and decide which science backs this method that you're going to use. And then you can look your collaborators, your physicians, and your patients in the eye and say, I'm doing it right here. And the laboratory won't be pushing back.
I think when a lab has to close the bite a little bit, it's much easier for them. I think that results in fewer issues on delivery. It's when they have to open the bite, I think that it creates some issues in some patients. But it's not like it's not adjustable in the mouth. I mean, you can adjust it. You just need to know what to do.
So here's a good question coming in. Do you make a difference between males and females, between small and large arches, between, like Keith says, BFTs and normal sized tongues? Do you talk about a little bit about categories like that?
So you mean
For
appliance?
vertical. Sorry, for vertical.
On vertical, yes. So I follow Dan Lewandowski's work. I mean, there's very little published. If there was more published on vertical, I would have had it on the slides. There's very little published, and Dan's studies are not huge numbers, not huge N numbers, but that's the only thing we've got to depend on. And there's pretty good consistency in his a number of studies that he's put out on this. So a bigger tongue, bigger guy, higher BMI, male, is going to benefit from a higher vertical. More petite individual is going to benefit from a lower vertical. So I would tend to try and you have a petite female with a small arch. Do you really want to be cranking them open? Think even intuitively, it's unlikely to be comfortable for them. The truth is, they seem to benefit from a smaller vertical, at least according to Dan Lewandowski's work. And that's the only thing we've got published to be able to refer to. Other than that, it's just speculation.
So even the science guy slips the word intuitively in there every now and then, John.
Well, you like, I hate filling in the blanks.
Yeah.
But there's some things you have to, because there's just no information there, right? So then you've got to use your best gut feeling based on what you know from the evidence. Otherwise, you can't do anything. Otherwise, you come to a standstill, right?
Yeah. Our friend Kevin Quishan says it's a thinking person's game.
Yes.
Yeah. So, all right. What else would you like that people know? Any thoughts occurred to you that you'd like to wrap this up with?
Appreciate the opportunity to talk about this. I really enjoyed putting this presentation together. It was really interesting to me because I had bits and pieces of this, in my regular presentations, but actually sort of comb you know, the literature and see what else I could find. And this is what it distilled down to. And so I learned a lot. It confirmed what my beliefs were, but it solidified them, I think is probably a better way to put it. So it was a lot of fun for me. So I appreciate it, Steve.
So I certainly think you've given us a lot to think about. I think you produced a wonderful webinar that will be watched over and over and over again for dentists who really want to do this correctly. And, you know, I hope that everybody gets a chance to get their questions answered. Take the CE questions, and that'll help reinforce what it is that you just saw. So that'll be excellent for you. And I really appreciate Panthera Dental for supporting this webinar. I think that you're going to be able to see good data across many, many years of usefulness because of what you've done for us, Dr. Viviano, and what Panthera did to support this, and of course, MedMark Media and Dental Sleep Practice Magazine. So if you've enjoyed this, tell your friends, tell them to come watch this webinar, and I hope that you all enjoy the magazine going forward and learn and learn and learn and learn to help as many patients as you can. Thank you.